Greetings and welcome to this video on Trimethoprim-Sulfamethoxazole, commonly called Cotrimoxazole and also in brand names available in India as Bactrim DS, Safran DS. These drugs are very useful drugs in case of chronic atypical infections, even the excellent drug for pyelonephritis these days. It's basically a double-edged sword used in clinical practice in specific use scenarios. In this antibiotic series, now today we'll discuss about Cotrimoxazole. So, if you're new to this channel, do subscribe. This is Medicine Beyond Harrison's. Let's get started. So, why this matters? Because the broad spectrum oral and IV drug can be given IV also. That most settings don't use this IV combination nowadays. So it covers this pneumocystis, even the MRSA, skin and soft tissue infections of MRSA can be covered by Cotrimoxazole and Stenotrophomonas it covers. Has an excellent tissue and CSF penetration, unlike this tetracycline group and vancomycin group, which have low CSF penetration. This has a very good CSF penetration. The danger zone, it has high toxicity ceiling, dose and duration dependent toxicity, and a common cause of pseudo-renal failure. That means creatinine can rise, but it will not be an actual renal failure. We'll discuss about it in upcoming slides. There can be hyperkalemia. So mechanism is sequential folate pathway blockade. It stops the folate synthesis in at least two steps in pathway. One inhibits the dihydroteroid synthase, which is the sulfamethoxazole, and trimethoprim inhibits dihydrofolate reductase. So in both these will decrease the folic acid synthesis and the leads to synergistic bactericidal effect. So it is basically a bactericidal drug and not a bacteriostatic drug. Without the synthesis of the DNA of an organism, that organism cannot survive. So hence it is a bactericidal drug. So antifolate effects also explains the major toxicities of this drug. Contraindications mainly sulfa allergy. The sulfamethoxazole component has sulfa group, and allergic don't use this. In G6PD deficiency, there is high chance of hemolysis risk. Always ensure anemia and patients with having G6PD deficiency families they don't give this drug. In case of acute renal failure, there is a relative contraindication not to give this drug because it is excreted through the kidneys. So trimethoprim blocks the ENaC channel, so it actually acts as an amyloid-like effect. So it causes hyperkalemia. Always check baseline potassium and creatinine before starting on cotrimoxazole. The drug-drug interaction, it competes with dofetilide, which is an arrhythmia drug. It can cause arrhythmia risk, and methotrexate can cause bone marrow toxicity. Also inhibits cytochrome P C9, especially, and inhibits the effect of warfarin, phenytoin, and phenobarbital. See, inhibits cytochrome 2C9, so it increases the effect of warfarin, phenytoin, and phenobarbital. These drugs are very toxic drugs and very important drugs to be considered before giving an Pseudo-Nephrotoxicity. So critical INR monitoring is mandatory when you are giving a cotrimoxazole and the patient is on warfarin. So nephrotoxicity is the main thing that you need to understand for this trimethoprim sulfamethoxazole. This TMP component of this drug inhibits the tubular creatinine secretion. So because of that, there is a reversible 30 to 10 to 30 percentage rise in creatinine. It is not actually a true AKI because creatinine is not able to get secreted because of the competition with trimethoprim. It is causing pseudo-nephrotoxicity. Again, crystals. This sulfamethoxazole component can cause precipitation and form crystals. The more the acidic urine, more the crystal formation. Again, interstitial nephritis due to hypersensitivity reaction to the drug, they can cause rash, fever, eosinophilia, and sterile pyuria. Can even lead to DRESS syndrome. So preventing nephrotoxicity, use lowest effective dose, monitor for renal function closely, stop other nephrotoxins, maintain the urine flow alkaline, alkalinize the urine if needed if there is presence of crystals, and always stop the drug if there is an hypersensitivity reaction. So other major adverse effects are hyperkalemia, like amyloid-like effect. We have to remember this before initiating a patient on sulfamethoxazole, trimethoprim sulfamethoxazole. Fluid overload, especially in IV formulation, and there can be drug fever, which is an hypersensitivity type of reaction. There can be mild rash. Rarely, SJS toxic epidermal necrolysis can happen. Anaphylaxis can happen. There is higher risk of hypersensitivity in patients with HIV. We specifically give this drug for pneumocystis pneumonia in an HIV infected patient. Always ensure to when there is a rash or SJS or anaphylaxis development, stop the drug immediately. Rare toxicities, it can cause drug-induced aseptic meningitis, seizures, confusion. Risk is increased with more than 7 days of therapy. Hematologically, there can be megaloblastic anemia due to folate synthesis inhibition, aplastic anemia due to bone marrow suppression, neutropenia, thrombocytopenia, and methemoglobinemia. Major hematologic manifestations can happen Increased turnover, there can be cholestasis, pancreatitis, severe nausea and vomiting. So these can also happen in case of usage of trimethoprim-sulfamethoxazole. So it is a very good choice and a very good drug, but has a lot of adverse effects. That's why before coming into the indications of trimethoprim-sulfamethoxazole, we are covering all the adverse effects and then coming to the pharmacokinetics. Then finally we'll go to the indications and the current use cases of this drug. So it is a dual coverage drug. It is mainly covers the pneumocystis and the bacteria, useful when options are limited. So excellent oral bioavailability with very good CNS penetration and high urinary concentration. Hence preferred drug for pyelonephritis. Toxicity rises with both dose as well as duration. So it can be used for group A and group B streptococcus. Previously it is considered not to be used. Now it covers that also. Because almost all the organisms have a DNA synthesis and have folate dihydrofolate enzymes. These enzymes are present ubiquitously in all the bacteria. So it is the because of the adverse effects, it is less commonly used. And based on the pharmacodynamics and the preference of beta lactam, we are not using this. Yet it is a very good drug for almost all these organisms that is mentioned. MSSA and 60% of MRSA are sensitive to this Cotrimoxazole, Streptococcus pneumonia, Staphylococcus saprophyticus, and the only thing it does not cover is the Enterococcus. So always remember that don't use it for Enterococcus and Pseudomonas. The Cotrimoxazole does not cover for these two organisms. It can be used for this rat fever, Stenotrophomonas maltophilia, and Enterobacteriaceae, variable penetration. Always use it after culture reports are obtained. No, do not use it empirically. For others, Pneumocystis jirovecii pneumonia, nowadays it is the drug of choice. For nocardia, it is a drug of choice. For listeria, it is a drug of choice. And toxoplasmosis, it is a drug of choice. So only for Enterococcus and Pseudomonas, do not use this drug. Otherwise, it is has a wide spectrum of activity and also a wide spectrum of adverse effects. Clinical uses nowadays for pneumonia, resistant limits is empiric usage. So previously it was used, nowadays it's not. For UTI and prostatitis, it's a drug of choice. UTI in case of pyelonephritis, this becomes the go-to drug of choice. Intra-abdominal infections, you can use this, but better drugs are available, so it's not preferably used. Chronic cellulitis also you can use, but better alternatives with beta-lactams and targeted therapies are there, so hence it's not used. MRSA, skin and soft tissue, even doxycycline can be used. For this Septran Cotrimoxazole can also be used. The Pneumocystis jirovecii forms a drug of choice. Listeria is a drug of choice. Toxoplasma is drug of choice. Legionella, you can use this and adjunct with doxycycline or in monotherapy. It is always inferior to vancomycin for a bacteremia case, so we do not use this for a patient with bacteremia. Always lysis of alcohol leads to rapid destruction of bacteria, and when this drug will go penetrate into the cells, suppress the enzymes, then only will kill the bacteria. It takes a longer time to think. A lot of failure rates can happen. The mutation of the bacteria can happen. So, hence, this is not perfect. When you have a better drug such as beta-lactam that is sensitive. Core regimens, single strength is for 80 bar 400 milligram, and our double strength is 160 bar 800 milligram. So nowadays double strength doses are preferred for pneumocystis jirovecii. Traditionally 50 milligram per kg per day is given in 3 to 4 doses. Now it is 10 milligram per kg per day to reduce toxicity. IV therapy can also be given for moderate to severe infections. Oral is acceptable if absorption is intact. So now most of the tablets available these days are double strength tablets with 160 to 800 milligram, 160 by 800 milligram. So ICU standard is 10 milligram per kg per day in 2 to 3 divided doses. Skin and soft tissue infections, 1 or 2 double strength tablets Q12 early. For UTI, it's 5 milligram per kg per day. That is double strength tablet twice daily. That will come around this therapy. So more than 5 milligram per kg reduces failure of treatment in case of skin and soft tissue infections. So adjust for GFR. When GFR is less than 30, give only 50 to 75% of dose. Case of less than 50, avoid unless it is PJP. So for obesity, adjust based on the body weight. So again, coming to the pharmacology and key takeaways, bioavailability is almost 90% oral bioavailability, oral bioavailability, and good CSF penetration about 40%. Half-life around 10 hours with increase in renal failure. Elimination is in renal and excreted unchanged. Hence, it can cause hyperkalemia, pseudo-nephrotoxicity, and this interstitial nephritis, which has an allergic reaction. So it is a very powerful drug, but unforgiving. Many adverse side effects are present. So always consider all those things and go for this drug. Especially special use cases is pneumocystis pneumonia, Stenotrophomonas, MRSA, skin and soft tissue infections, including MRSA and nocardiosis. So there is a severe renal failure, hyperkalemia, and high toxicity risk for this drug, which limits its usage. We learned a lot about this drugs, Trimethoprim-Sulfamethoxazole, and use this in clinical practice with confidence. These are taken from the IDSC standard guidelines and Sanford and Fishman textbook with references from up to date. If you're new to this channel, do subscribe. This is Medicine Beyond Harrison's. This antibiotic series, we'll discuss more about these drugs in the upcoming videos. Thank you for watching.